Dr. Fardina?
Thank you, Prof. Fitzgerald. Good afternoon, everyone. Thank you so much for attending today. Following Dr. Tan's lecture on triple-negative breast cancer, I'm also going to speak on breast cancer because undeniably it is the most common cancer in Malaysia. My topic will be on new kid on the block. So literally, what's the newest therapeutic that's dominating the oncology world, and that's antibody drug conjugate in advanced breast cancer. So honestly, I can't tell you how many times I sit in my clinic and how frustrated I get with the bad press that chemotherapy is getting. Most of my patients come in and they say the one thing they don't want to hear is the word chemo. The reason for that is, I mean, we do have media and movies sort of making lots of films about women going through chemotherapy with so much toxicity, balding hair, and getting really thin. But the truth is, the new kid on the block, which is antibody drug conjugate, the main thing that it's coming in to try and do is widen the therapeutic window by increasing its efficacy and its effectiveness and reducing its toxicity. So what is it? What is this molecule? It literally is chemotherapy here, which is called the cytotoxic payload, here delivering chemotherapy. And there's an antibody up here that recognizes the cancer cell. And there's a linker here, which then attaches the cytotoxic payload to the ADC. So how is it different then? So it is, in effect, delivering chemotherapeutic target to the cancer cell. However, the way that it's doing is selecting those cancer cells. By selecting out those cancer cells, this ADC is then able to reduce toxicity that we hear in the press, and hopefully a lot more of our patients are able to tolerate the treatment much better. What is the mechanism of action of ADC? Literally, the main aim of the game is the antibody to target. So once the antibody is able to target, then they deploy the cytotoxic payload into the cell. As you can see here, the ADC comes into the microenvironment, and it's the antibody to target combination here, then and degradation and the linker being cleavable, and then producing the cytotoxic payload or chemotherapy into the cell, and then having the effect of killing those cancer cells. But also, it has a bystander effect, meaning the cytotoxic payload can go to the neighboring cancer cells and also kill the neighboring cancer cell in that way, and then increasing the efficacy of ADC. In terms of ADC in advanced or metastatic breast cancer, we have a few, and actually there are a lot more ADC that's coming up in the market, and it's getting really tricky to try and keep up. So in terms of ADC, it has been there before. Back in 2013, FDA did approve TDM1 or trastuzumab emtansine for the management of HER2 breast cancer. And then after that, we have a lot more ADC coming up more recently, like trastuzumab deruxtecan or TDXD, SASI, we call it the sexy name, sacituzumab govitecan or SASI, and dato-DXD. So all this ADC has its target, where it binds and it finds those targets before going into the cell. And the target can be HER2 or it can be TROP2. And it then deploys the payload or the cytotoxic chemotherapy into the cell for the mechanism of action. And it has drug to antibody ratio, meaning for one antibody, if there's a lot more drug into that molecule, then clearly the efficacy is going to increase. So you can see here, TDXD has 8:1 drug to antibody ratio, or known as DAC. And so we're looking at that, SASI has 7.5 to 8:1 DAC. So that sort of translates to us how effective this molecule can be. And we look at the target population, meaning the breast cancer population that Dr. Tan just mentioned just now. There are different subtypes of breast cancer out there. And for the HER2 positive breast cancer, we can use specific ADC compared to for triple negative breast cancer, we have sacituzumab govitecan and DETU-DXd. So, why rambutan? We know just now, Dr. Tan mentioned about the cancer cell, and the cancer cell has receptors on it. So that receptors literally is just like the hair on your rambutan. So next time when you're eating rambutan, just think again about what that can mean. Like it could be like cancer cell and you're being targeting the hair cells on there. And that can be the HER2 positive breast cancer that's sitting on there, and we want to target those hair on your rambutan, and that's how the ADC is being developed. So previously we have TDM1. Hang on a minute, Nina, what is Luke Skywalker doing there? So that Luke Skywalker is really literally mentioning the old force of Star Wars, right? Because TDM1 has been here for some time. So, and we've mentioned that TDM1, it goes to the HER2, right, before it comes in, and then it deploys its cytotoxic payload. And so how does that look and compare to the new force of Star Wars? And the new force of Star Wars is really right here, which is TDXD. So now we can't forget anymore about ADC because we've got our characters from Star Wars here to help you. But basically, TDXD is different because it has high DAC, which we mentioned before. So it's a little bit different in terms of our TDM1. So high potency of payload, and it has stable linker payload and tumor selective cleavable linker. Meaning when it goes into the cancer cell, then it deploys its activity trying to reduce toxicity to the rest of the body, right? And so I introduced the Destiny's trial. So the Destiny trial is really looking at TDXD in its development. And here is Destiny 01, really at that beginning of the journey for TDXD. At that time, we were looking mainly, they're looking at the activity of TDXD in patients who've already been heavily pretreated. But you can see here, looking at the waterfall plot that Prof. Ho already showed us before, the beautiful waterfall plot, but look at the overall response rate here is pretty impressive for patients who've been heavily treated before. So hence then they brought TDXD to earlier part, and here we have Destiny 02, where it's being randomized TDXD versus physician's choice of chemotherapy. And then we see here at primary analysis data cutoff and duration of follow-up in the TDXD arm, you can see that the median survival is 21 months versus in TPC or chemo it's about 18.6 months. And these patients have been treated before with TDM1. So it's saying that even though patients who've been treated with ADC before, they're still seeing activity with another ADC. And here we can see the primary endpoint by progression-free survival. As oncologists, we love curves, and we love it to see when the curves separate early and it's sustainable, and the separation of the curve is huge there. And you can see there that clearly TDXD median PFS is about 18 months versus chemotherapy about 7 months. So that's a huge gain if you're treating our patients with ADC. And the ultimate match really in the Star Wars is between the old force and the new force is between TDM1 and TDXD, and we have here Destiny 03. And in that we look at patients who been randomized between TDXD and TDM1, and then we want to see what's the result of that. And you can see here that the duration of response for patients in the TDXD arm is much longer, about 30 months versus patients who've been treated with TDM1 at 17 months. So that's a staggering benefit that we can see. And in here, clearly the new force is winning the battle. And even by PFS2, you can see that TDXD, which is really the blue line here, is having a much improved PFS2 at 45 months versus TDM1 at 23 months. And the most important question in oncology is, so what about lifespan? Are my patients living longer? And you can see that even in overall survival, that patients, overall survival for patients being treated with TDXD was about 52 months versus patients who've been treated with TDM1 at 42 months. That's 10 months increase. But we talked just now in terms of toxicity, right? So we talked about how it can be selective and reduction in toxicity is being seen in our patients. However, we do have to bring forth that there is certain toxicity that we do have to be mindful about. So as an oncologist, you do have to learn about the tools that you have in your box and what toxicity you need to watch out for. And for TDXD, the main, one of the main side effects that we need to watch out for is interstitial lung disease. So meaning pulmonary fibrosis or breathlessness and cough. As a medical doctor, then you would have to be very concerned about that. And there are a lot of different steps that you can do to reduce that side effect. In terms of sequencing ADC, I will go that in a little bit deeper a bit later. What about HER2 negative breast cancer? So we're talking about HER2 low, and in HER2 low, really in those patients that have HER2 1 plus or 2 plus. So we're just looking, and the ISH is negative. So can we even target those with ADC? And the two ADCs approved in the HER2 negative metastatic breast cancer is really sacituzumab govitecan and TDXD. And here I introduce to you another ADC, which is SASI. So SASI is not against HER2, it's really against this antibody called TROP2. And TROP2 is being expressed by a lot of different solid cancer cells, solid tumor. So it's not rambutan anymore, you can think about it as a durian. So it still has some edges on its, on the fruit, right? Which you can target, but it's not HER2 anymore, it's TROP2 that you're targeting now. But you're deploying then the cytotoxic payload still into the cancer cell. And here, again, we look at the population of triple-negative breast cancer, but more in the advanced setting. Dr. Tan mentioned just now, more in the early setting. So sacituzumab, looking at the late setting, we can hear in the ESSENCE study that it still has ORR, or objective response rate, of about 35% versus 5% looking at normal chemotherapy. And TDXD, again, even though it's directed against HER2, it still has activity in HER2 low patients. So we can still use it for HER2 low patients. And this is SASI in TROPiCS-02 in the hormone receptor positive patients who've already had chemotherapy before. ADC can still be used in this setting. So again, we come back to this slide about ADC and all the different ADC that's coming out right now, or different drugs that are being manufactured right now, looking at the landscape of metastatic breast cancer. We had TDM1 and TDXD, and then we have sacituzumab govitecan and TDXD, mainly looking at the HER2 positive or TNBC landscape, and now we have datopotamab deruxtecan in the TNBC landscape. And Dato is being looked in the TROPION study. And all this will not happen if our patients are not included in the clinical trial. So we have our patients represented in the clinical trial in ADC that's then able to move our research further and then move therapeutic landscape further in our patients. What about if you failed one ADC, and then do you re-challenge them with another ADC? Honestly, this is a very, very difficult question to answer because we don't really have that much data in this. But in terms of thinking about it, we have to think about target resistance, meaning what are you targeting, HER2 or TROP2 versus payload payload resistance, meaning is the cancer cell resisting the chemotherapy. But most of the time we see what's happening is a target resistance, so in terms of the HER2 or the TROP2, and so perhaps if we challenge it with a different ADC, that might work. However, so far in the data that we have, after being challenged with the first ADC, the median PFS with the second ADC is still very low at about 2 to 3 months. There are some trials that are being done looking at ADC sequencing, so one ADC after another, for example, first TDM1 and then TDXD, and then so looking into that, and there is still some activity there. However, when we're looking at the newer ADC, maybe the benefit with the second ADC isn't as promising. And it's already here to stay in terms of ADC because it's already in the international guidelines. But sequencing ADC is going to be a tricky question to answer yet. This is just a big shout out to Cancer Echo University Malaya, because we are part of an educational network that basically gives free educational webinar. So it's online, you just Google search Cancer Echo UM and you can be part of our network. Thank you so much.